open the third session, I believe we owe a well-deserved thanks to the organizing committee for arranging such a sumptuous lunch. So thank you to all concerned in this regard. Moving on, let us begin the lectures for the session, which will tackle head-on such inevitable topics as management of spinal injury complications, effective discharge planning to equip appropriate home care, and most importantly, de-stressing techniques for nurses engaged in such high-stress neurotrauma care. To that end, I would now announce and invite to our dais our distinguished chairpersons for the session, beginning with Honorable Professor Dr. A.K. Mahapatra, sir, followed by esteemed Dr. Shashi Marwar, ma'am, and our beloved DNS, Ms. Indumati Kullu, ma'am. Professor Dr. A.K. Mahapatra, he is the Professor of Neurosurgery, AIIMS, New Delhi. His awards and honors are Gold Medal for Best Papers in various conferences, ICMR Awards 1992, Boy Scouts Fellowship, Government of India 1987, Traveling Fellowship by ISPN, International Society for Pediatric Neurosurgery 1995-2001, Excellent Paper Awards at Asian Oceanian Skull-Based Surgery at Tokyo, Japan 2002, and Pan-Arab Journal Neurosurgery 2005. He has successfully carried out over a dozen projects in the last 20 years. He has under his belt 7 and 3 multicentric studies performed both nationally and internationally respectively. He has also accomplished numerous researches on the topics of neural transport, evoked potential, and many more. Thank you, sir, for being here. Dr. Shashi Marwar, Associate Professor and Vice Principal, College of Nursing, AIIMS, New Delhi. Her award and honors are Best Paper Award at Jericon 2017, New Delhi, Best Paper Award at IAPSM Conference 2016, Distinguished Service Award for CME Contribution in Cardiology in the World at WCC PCI 2016 by Dr. Harshvardhan, Minister of Science and Technology, Government of India. WHO Fellowship of Economic Evaluation of Disease Burden, organized at HITAP, Thailand, Ministry of Health and Family Welfare 2012. AIIMS of America Award for Best Research Paper for 2005 at AIIMS Convocation. Thank you, ma'am, for being here. Ms. Indumati Kullu, Deputy Nursing Superintendent, Jayaprakash Narayan Apex Trauma Center, AIIMS, New Delhi. She was awarded the Best Management of OT, ED, and Wards, Jayaprakash Narayan Apex Trauma Center, New Delhi. She is known particularly for her cheerful disposition, proficient management skills, and for creating a stress-free and conductive workplace for all her staff. Thank you, ma'am, for being here. Once again, reminding afresh, before our distinguished chairpersons duly announce and introduce our speakers, speakers are requested to kindly cooperate and adhere to the predetermined time slots assigned to them. Thank you.
Thank you, organizers, for the kind words. And with this, I'm going to begin with the first session by Ms. Sibi, who is going to talk about nurses in management of complications associated with spinal injuries. She is working as an associate professor at College of Nursing, AIIMS, New Delhi. She has several feathers in her cap. She is a lifetime member of several associations like TNAI, National Scholar Society, and Nurses Teacher Association. She is also a reviewer of a textbook of Medical Surgical Nursing Southeast Asia edition by Elsevier. She is also editor of another medical surgical books which is on nursing clinical skills, which is also a manual by Elsevier. And she is a trained ACLS and BLS instructor. And she has interest in teaching as well as research, and she is more tilted for medical surgical towards nursing. With this, I welcome Ms. Sibi for the session.
Thank you, ma'am, for the gracious introduction. Good afternoon, respected faculty members on the dais and all the respected delegates. At the outset, I would like to thank the organizers of the ANPC conference for inviting me for this and letting me be a part of this wonderful conference, and especially the organizers of the Neurotrauma Symposium, Ms. Sonia and her team, for making me a part of this endeavor. So the topic allotted to me is nurses in management of complications associated with spinal cord injuries. So when we are talking of spinal cord injury, it is an injury that can result in a multiple motor and sensory deficits and can leave a person with much of a burden of care, and also this impairment of these functions can result in significant psychological as well as social consequences of the patient. And we all know it is most commonly a result of any road traffic accidents, falls, sports related or diving into water, and management in the acute phase followed by management in preventing the complications is the utmost care of a spinal cord injury patient. Moving on to the topic that is the complications associated with we have a host of complications which are associated with spinal cord injuries. As the time is limited, I will be only touching on the limited complications such as pressure injury, autonomic dysreflexia, pneumonia and retained secretions, urinary tract infections, constipations, deep vein thrombosis and spasticity. So pressure injuries, we all know pressure injuries are due to the triad which is acting on the patient of pressure, friction and moisture in which the skin breaks down. So the nurse's role is very paramount in preventing the pressure source injuries. The first and foremost is the skin assessment. A visual check of the skin once in every shift is most appropriate, and any signs of any skin breakdown, any redness, any blanching, any induration, any heat, hot areas of the skin should be noted. Nutrition and hydration plays a very important role. Most of the patients on spinal cord injuries, they will be on enteral nutrition, a regular follow-up, a strict intake output chart, and proper nutrition, a high protein diet would be beneficial for maintaining the skin structure. Incontinence care, all these patients of spinal cord injuries, they may have bowel and bladder dysfunctions leading them to be incontinent and incapable of managing the bowel and bladder. So incontinence care is paramount in prevention of the skin breakdown. Patients having an episode of incontinent bowel or bladder, the skin should be kept dry. The appropriate size incontinent pads can be used. The skin should be kept dry at all times. If any episode of leaking is happening, the skin should not be vigorously rubbed. It should only be dabbed, and the skin should be kept clean and dry at all times. Care of medical devices. All these patients would have a host of medical devices which is attached to the patient, like the patient might be on pulse oximeter, the patient may have a BP cuff attached, the patient may have an abdominal binder. All these, if it's very constrictive and if it's kept for a long period of time, may promote the skin breakdown. So the care of medical devices is paramount. The medical devices can be, if the sites can be rotated, it can be rotated, and care should be taken while in the visual examination of the skin. It should be noted that the patient is not unintentionally lying on the medical devices, which may again aggravate the skin breakdown. Frequent turning and repositioning is very important to take off the weight of the patient so that the pressure points are relieved. And range of motion exercises, a regular schedule of all the passive and active range of motion exercises should be initiated very early, and it is very helpful to maintain the venous drainage and to maintain the skin texture. Autonomic dysreflexia is again a very important complication and a very much manageable complication if it is if it is diagnosed early or detected early. So what is happening in autonomic dysreflexia is, it is a condition in which the autonomic nervous system, it has an abnormal excessive response to the noxious stimuli below the level of injury. What is happening is any stimuli below the level of injury can stimulate an exaggerated response in the patient, because the brain is not able to send the messages down the level of injury. As a result, the stimuli will be over exaggerated and the patient can present with a variety of signs and symptoms which will be discussed later. It can be a clinical emergency. The more rostral the level of injury, or the more higher the level of injury, the more prone the patient is to this complication, and it can be life-threatening if it is not immediately managed. So the most common causes, any stimuli which is constricting to the patient. It can be a full bladder, or it can be tight clothing on the patient. It can be the presence of pressure sores. It can be an ingrown toenail. It can be any presence of any fractures, any constrictive medical devices on the patient, or pain sensation of the patient. These all can stimulate the autonomic dysreflexia, and the patient can exhibit signs of hypertension, bradycardia. In most of the patients, bradycardia and hypertension are the only symptoms which can be visible, and it should be treated as fast as possible. The patient may also complain of severe pounding headache, skin rashes, profuse sweating. The patient may have a cool and clammy skin. The patient may also have blurred vision, pupillary dilation may be there. The patient may be very anxious, nasal congestion, nausea. If these symptoms are in a patient, and we are seeing that the patient the urine bag is very full, it is it is tugging on to the catheter of the patient, or the patient is having any pressure source, patient is complaining of pain, then immediate measures should be taken. So it can be managed by removing all these noxious stimuli which we have discussed earlier. We can loosen the clothing if we see that the clothing is very tight, or we can relieve the constrictive medical devices. We can remove the compression stockings or the abdominal binder which the patient is on. We can perform a urinary catheterization. The patient is already not catheterized. It may be a full bladder, and the patient may be having bladder retention, and we can see that the abdomen is distended. We can put in a urinary catheter, and we can have bowel disimpaction. The patient has not had a bowel movement, and we can feel that the abdomen is too much distended. We can have a bowel disimpaction using a digital removal. We can use that. We can do that. We can look for any pressure sores, any ingrown toenails, and accordingly manage. The position of the head of the patient should be kept elevated for the comfort. We have to monitor BP and heart rate regularly, and if any stimuli is found out, we can remove that stimuli, and even after that patient is having high BP, patient going into bradycardia, we can initiate antihypertensive therapies if it is not already initiated. The next complication is pneumonia and breathing difficulties. So patients of spinal cord injury, especially the level being higher than T6 and all, the patient would be having a respiratory problems. The patient may have an improper breathing pattern, and the patient will, when we are getting the patient in our ICUs and wards, the patient may be in the emergency, they have already may be mechanically ventilated. Such patients' respiratory rate and the patient's breathing effort should be noted frequently. We have to assess the respiratory functions periodically. We can monitor the SpO2 readings, the EtCO2 readings, etc. And then we can, if the patient is on ventilator, we know that because of the patient's bedbound status and the patient's altered status, the patient may also go into ventilatory VAP, and we can initiate prevention strategies as soon as possible. We have to give oxygen as required. And one more thing which we can see is that we have to ensure that the abdomen is not distended. Why is it important here is because an abdomen distension with the fluids and all, the patient can have vomiting, and if vomiting is induced, the patient, because patient is bedbound, it can lead to aspiration pneumonia. That can all further exaggerate the conditions. So we can initiate VAP prevention strategies. We can practice need-based suctioning, strict hand hygiene. Strict hand hygiene is very necessary. All the 5 moments of hand hygiene should be adhered to very carefully, and it can go a long way in preventing hospital-acquired infections in the patient, especially VAP. And we can also practice need-based suctioning. Oral care with chlorhexidine can be initiated and can be done on a daily basis. Head of bed should be elevated to 30 to 40 degrees. And we have to prevent aspiration by verifying every time that the feeding tube or the rice tube placement has to be verified every time. And also we can verify ET tube cuff pressure. The pressure should be kept between 20 to 30 centimeters of water. Then moving on to another complication, urinary tract infections. It also most common complications which are presented by spinal cord injury patients. So in the acute phase, we are managing the urinary tract with the help of an indwelling catheter. So whenever the indwelling catheter is to be introduced again, or if the patient is practicing intermittent catheterization, then it should be lubricated to prevent the injuries. And if the patient is put on if the patient is put on long-term management for the urinary tract management by catheterization and all, the patient should be taught clean intermittent catheterization, condom drainage, or even the suprapubic catheter use can also be evaluated. Then we have to maintain good hydration, because we know UTI is predisposed in the event of not maintaining good adequate fluid intake, and also it also decreases the risk of kidney stones because the patient is not moving much. Good hand hygiene by the carer, especially when we are giving the urinary tract care, then good hygiene should be practiced, and the perineal area also should be kept clean and dry to prevent the infections. Constipation is also very common because the patient may have an incontinent or incontinent bowel, and the patient may be complicated with having the stools passed infrequently, with the patient not being able to manage his or her own bowel movements. So for this we have to assess bowel movements on a periodic basis. We can do the abdominal auscultation and listen to the bowel sounds. We can we can ask for the bowel movements. We can make the patient stay hydrated by maintaining the strict intake output maintenance. Then we can have the patient, when the patient goes into home and the patient is on normal flow for foods, we can ensure the patient is having food which is high in fibers, fruits, vegetables. We can avoid stimulants like tea, coffee, and also in the spinal cord injury, what is happening is the stool evacuation is not proper. So for that we can administer laxatives, and if we feel that there is fecal impaction in the rectum, so we can have a digital removal with a gloved hand, lubricated hand. We can have the digital removal of the feces, and we can have the digital rectal stimulation. So if we find that the stool is impacted, so first we will attempt the digital removal, gloved digital removal of feces, followed by giving a stimulant. For example, a short enema can be given for the patient to pass his stools. Then spasticities, that is also one of the main complications of spinal cord injury. There is a triad of, patient is bedbound, there is venous stasis which is occurring, patient is already patient is having an injury which is leading to the endothelial injury of the vessels, and the patient is also in a hypercoagulable state due to the inflammatory markers, increase of inflammation in the body. So the patient is all more prone to get the spasticity. So again, spasticity again an exaggerated response of the muscles, and the muscles may go into spastic, going into flexion or extension. So for that, stimulus, we have to check for any stimulus. For example, as already told in autonomic dysreflexia, any stimulus which is there in the patient, for example, any pressure source or any constipation, any bladder infections, that may result in the muscles to go into spasticity. So we have to remove the stimulus as and when it is identified. We can go for the active passive range of motion exercises of regular massaging, stretching, weight bearing, and also electrical stimulation. Transcutaneous electrical nerve stimulation has also proven to be benefit or to reduce the spasticity in spinal cord injury patients. We can also go for medical management of baclofen, gabapentin, etc. Then we have the last complication to be discussed, that is a deep vein thrombosis. So deep vein thrombosis, again, it is due to the venous stasis and venous pooling of the blood. So we can have the mechanical prophylaxis measures of stockings we can give the patients to wear. We can have intermittent pneumatic compression or the sequential compressive devices. DVT pumps can be therapeutically added to the patient's therapy. Pharmacological prophylaxis of starting warfarin or subcutaneous heparin or low molecular weight heparins can be started. Early mobilization can be encouraged in the patient so that the patient has a mobility and the venous stasis is resolved. And we can also have active and passive range of motion exercises in the form of stretching, massaging, rolling, etc. So that was all. To conclude, nurses are an integral part of the spinal cord injury rehabilitation team and is in a very good position to provide significant education and also observation of the patient and accordingly manage, and also give significant education to the patient and family about the intricacies of living with spinal cord injury, as well as help manage the care process and prevent complications. So this was all. Thank you.
Thank you, Sibbi, for comprehensively covering the nursing management of all the complications, and she has highlighted very well regarding VAP management as well as DVT management and even the smallest complication like constipation, etc. And if there are any questions, should we take it at the end, or any questions from the participants or any comments?
I have just one comment. See, Music Therapy Institute in Los Angeles started in 1940. If you go to many of our neurosurgery wards, there is light music. So the nurses have got a stimulating role, motivating role. It's not only nursing care. You are the mentor for them. You are the family member. There is nobody there in ICU. So you should see that a holistic approach.
Yes.
It's not that whatever you say, a robot can do it. But there is no human touch. You see, it's also a classical
yes.
textbook of what to do. This. Nahin? But then there is human touch, ethical problem, motivation and stimulation, and create a positive energy. You are okay. All is well. Have you seen Three Idiots? Three Idiots? Yes. What is word? All is well. All is well. So make it music there which is positive.
Yes.
I
Yes,
say,
sir, I agree with
if
that.
you are Hindu, you have a morning Gayatri mantra, throughout the Onkar mantra, Sham ko Mahamrutyunjay mantra. If you are Christian, put something. For Muslim, something. Namaz. Because the music is the greatest healer. Music in Los Angeles 1940, there is an Institute of Music. They give BSc, MSc, PhD music therapy for hospital. Not
Yes.
for going for Oscar.
Yes. So I also agree, in the neuro wards also we are practicing this diversional therapy, and yes, so music is also an integral part of the therapy, and even in the neuro wards also, everyone is on with the music headphones and they are listening to music every time, and that has improved to be effective. Thank you, sir. Yes, the whole holistic care of the patient, yes, and the therapeutic touch. And
Myself is Ramandeep from PGI Chandigarh. I have worked in Radhaswamy Hospital, Beas for 2 years from 96 to 98, sir. At that time, they used music for head injury patients. There is no neurosurgeon, but I have never seen any neurosurgery patient died in that hospital. It was managed by Dr. B.S. Through general surgeon. Maybe, sir, he is well known, you maybe know him. They used to Radhaswamy satsang by headphones on every patient's head. This is the fact.
Let me tell, only 2% head injury require operation, neurosurgery. Everybody may initially require acute care, which is best resuscitation, and some 1 or 2 days. Mostly if you take out the patient on 48 hours from ICU, they have better recovery. We dump in ICU as long as possible. Either the doctor wants to take it out or the family. For family it is easier, they are in ICU. The question is that quicker you rehabilitate it, better. And one of the rehabilitation is music therapy. That give him psychological rehabilitation, mental and spiritual rehabilitation. So depending on what religion you follow, it's a spiritual aspect of healing. There is a book called Spiritual Healing, written by Dr. Subramaniam, who was suffering from cancer, and one day he thought he should write a spiritual healing.
thanks, sir. Thank you.
Read that book, Supreme Doctor, Doctor above somebody.
Okay. Huh. Next, Eliama Biju. Next topic is discharge planning and home care for neurotrauma patient.
10 minutes talk, 5 minutes discussion.
Okay, sir. Thank you for the chairpersons and the organizers, sir. Today I talk about the discharge planning and the home care of neurotrauma patients. First of all, I will show a case scenario of a patient, 40 years old, brought to ED with history of RTA. On arrival, his disease was E4, V4, M5 and the weight is unstable. The patient put on ventilator. He remained in the ICU on the ventilator for 3 weeks and ward for another 2 weeks. He discharged from the hospital. At the time of the discharge, he was semi-conscious with RT, Ral's tube and urinary catheter. He had difficulties in speaking, writing, memory, and concentration. Because of the comprehensive and complaints to the instruction given by the doctors and nurses before the discharge, helped the patient to improvement in speaking, writing, and recognition of his family and mobility. What we learned from this scenario, if the patient admitted in our hospital, first during the hospital stay, we main important is the caregivers. Training of the caregiver is the main important things. They are more stress and anxiety for the patient's caregivers, and we trained well before the discharge. That will help release the stress and anxiety of the patient's caregivers, and it will also improve the quality of the patient's life. Objectives. Discharge planning is a very important element to prevent the post discharge complications, and we discuss all the home care to the caregivers of the patient, because these patients are a very difficult task for the caregivers to give the home care to the patients, because it is a patient can stay the hospital. It is a quite a long period of time the patient was in bedridden state. So we give a proper care training to the caregiver of the patients. In the healthcare teams included doctors, nurses, physiotherapists, and nutrition. These all are the main team of this care. And what is the ideal discharge planning? Ideal discharge planning, first I stands for the information. We include the family members and the patient for all the information about the discharge planning. Second, discussion. Discuss with the patients and family about the home care and review medications and their lab results, follow-up, OPD, and any warning signs, etc. And education. Educate the patients in a home care about in a simple language. We don't use more medical terms. And accessibility. Accessibility means we access to sure that the doctors and nurses are explaining to the diagnosis and treatment and the condition of the patient and next step care of the patients. And listening to the, we are listening to the patients and the caregivers goals and their goals and their feelings. Components of discharge planning. First is medical regime. Medical regime is ask the prescribed medicines to be given in a right time and in the right dose. Hygiene of the patient is mainly in neuro patients include the eye care, oral care, back care, and personal hygiene, catheter care, etc. Wound care and stitch removal. Most of the patients' sutures are removed within 10 to 14 days after the surgery, and after the surgery, and the wound site should be cleaned with soap and water, and we watch for any pain and swelling and discharge from the wound site also. Tracheostomy, suctioning and site care, feeding, bladder care, care of pressure points, ambulations, and exercise, prevention of infection, it will discuss in later. And follow-up care in OPD. Reporting emergency OPD. When the patient have a neurological complaints like a persistent headache, increased confusion and drowsiness of the patient, and the stiffness of the neck, and the onset of repeated onset of seizures, in these complaints we reported to the emergency OPD. And the respiratory complaints like shortness of breath, increased respiratory rate, and fever, respiratory infection, and GI complaints like nausea, vomiting, constipations, severe constipation and loose motion, visual and speech problems like slurring of speech, and fever above 101 Fahrenheit, and pain, redness, and discharge from the wound site. In these conditions, we report in the emergency OPD. What is home care? Home care of neurotrauma patients is a difficult task for the caregiver and the family, because they are bedridden for quite a long period of time after operation. They may develop so many complications like respiratory tract infection, urinary tract infection, severe constipation, diarrhea, etc. So if we give proper training up the hospitalization period, that will reduce the stress and anxiety of the caregiver, and but also it is improve the patient's quality of life. What are the problems in the patients after neurosurgery? Impaired communication. Impaired communication means it is because of some neurotrauma case. Because of neurotrauma, some patients are unable to speak. Otherwise, the patient is on tracheostomy, they can't express their feelings. That time we can use some communication strategies such as lip reading, writing and hand gestures, and some communication charts are also used. Infections like upper respiratory tract infection and urinary tract infection and constipation, diarrhea, already previous section explained, and decreased muscle strength of the patient, decreased mobility, muscle contractures and DVT. Deep vein thrombosis is a other complication for the patients. If in this case we are using, in hospital setup we are using for the the DVT machines. In home care setting we are advised for the crepe bandage, and this crepe bandage should be removed every 3 hourly and reapplied. Impaired communication, I already discussed. What are the challenges of the caregivers? The challenges are a physical strain of the patient, because the patient are not able to do anything independently, totally depend upon the caregivers of the patient, because the patient have sponge bath and training of the patient and suctioning, tube feeding and mobilization of patient. These all cares are given by the caregiver of the patient. So this is the physical strain of the caregiver. Mental strain, because of the, it is a prolonged recovery of the neurotrauma is a prolonged, it will take a prolonged time, so that they have anxiety about the improvement and the prognosis of the patients. Sleep disturbance is because of patient have a suction, they anytime patient needs suctioning and position, 2 hourly suctioning, 2 hourly position, that will also cause the sleep disturbance of the caregivers. Financial burden is also because of it is a long recovery is very long time, that will the treatment and the equipments used for the patients, like if a poor patient they can afford the air mattress and wheelchair and suction machine, these all cause the financial burden of the patient. Medication mainly the neurotrauma cases, we are anticonvulsant drugs, anticoagulant drugs are mainly used. Anticonvulsant drugs like eptoin tablet, tab levera can be advised for the patient. We have to any warning skin reactions of the drugs will also be notified. If the eptoin have some patient have skin rashes will occurs, and it is a side effect of the eptoin is anemia, and vitamin B12 deficiency and osteoporosis are the main side effect of these medicines. And if the patient, we also watch for the seizure of the patient on eptoin, it will also watch for, if the patient has seizure occurs within 14 days, serum eptoin level also we send for the patient. Wound care and stitch care. Mostly the stitches are removed from 10 to 14 days after the operation, and we watch for any pain, redness and discharge from the wound site. It should be cleaned with soap and water, and do not cover the head with any scarf, any cap, do not scratch the area. Tracheostomy care. Tracheostomy care includes mainly tracheostomy suctioning and tracheostomy site care. In our hospital, we prefer for a foot operated suction for every TT patients, and it can comfortable for the patient. The patient is socially economically low status, they can afford it, and otherwise some patients home have no electricity problems, and transportation of patient from hospital to home, we are advised for the foot operated suction machine. It is very difficult to operate. Then we learn the caregivers about a proper suctioning of the patient. The points to be remembered that keep the patient in a flat position, and suction hand hygiene to be maintained before and after doing any procedure, and hand hygiene and aseptic technique should be followed, and chest physiotherapy is also explained by the physiotherapist. Before the discharge, physiotherapist already advised to the patient's relatives. Suction the patient not more than 5 to 10 seconds, and allow the patient to 3 to 4 breaths between the suction also. And this tracheostomy suction, tracheostomy tube should be changed every 15 days. We should change the tracheostomy tube of the patient. If the patient is ventilator, we are using for cuffed tracheostomy tube, and if we plan for discharge, and we used for a uncuffed tube. And tracheostomy site care is also important. We clean with normal saline and dry dry with the gauze piece, always we cover the tracheostomy with a wet gauze piece. And if that tracheostomy tag will soiled, it also be changed with the assistance of two person. One person will hold the tracheostomy tag and the other person will remove the change the dressing of the patient. Feeding high protein, high calorie diet advised by the dietitian before the discharge. Mainly milk based diets and a curd based diet can be advised for the patient, and dal water, coconut water, these all feeds are advised for the dietitians. Food hygiene also maintained for the patient because of contaminated food and water cause diarrhea of the patient. Positioning of the patient to be elevated the head and 45-degree angle, and hand hygiene also maintained before feeding. And adequate intake is also important for this patient. If inadequate intake, that will cause constipation of the patient. In neuro cases, some patients have hyponatremic cases, their sodium level is low. That cases we advise the 1 to 1.5 liter fluid restriction will advise for these patients. So the patient relatives will know about that, the lab results also. Hygienic of patient is mainly eye care. Eye care, some patients have a corneal dryness will occur, so we tape the eyes, and prevention of the corneal dryness, we advise for the eye moisol eye drops and any lubricants like lacrygel lubricants can be used for the patient. Oral hygiene is also important because patient is getting RT feed. Prevention of the odor and the coating of the tongue, we give chlorhexidine mouthwash, advice for chlorhexidine mouthwash. Skin hygienes include all the back care and catheter care and sponge bath. These are the advice for the patient's relatives. Bladder care, most of the patient discharged with the Foley's catheter and the silicone catheter, and we advise the patient to remove the Foley's catheter every 14 days and silicone catheter every 21 days. EMC, external male catheter is also for advice for the patient. If we watch for any penile excoriation of the patient also. And catheter care is very important to prevent the urinary tract infections. And catheter clamping is also, we follow in our ward forwardly catheter clamping to the patient. It is a bladder training of the patient. And watch urine output also. Minimum 30 ml urine per hour is necessary for the patient. And sometimes retention of urine will also occur. So we watch for any clamping, any blockage of the catheter, and sometimes EMC was kinked. That time also retention of urine will occur. Bowel care, already ma'am explained previous section, and we watch for the bowel movements of the patient. In our ward we watch daily the bowel movements of the patient. If the patient is not passed stool within 72 hours, we advise for the stool softness and the enema. Care of the pressure points. Prevention of bed sore, we advise the patient for a air mattress. In home situation also we advise the patient for arrange for hair mattress that will prevent the bed sores. Back care and positioning, overly positioning the patient is important. Maintain the personal hygiene of the patients, and routine examination while we turning up the patients and giving back care. We check the skin skin to be assess the skin have any peelings and redness. And bed sore dressing, if patient have bed sore dressing also applied for the patient. Exercises, mainly breathing exercises through the spirometry. We give spirometry to all the patients in our ward. We first bring a spirometry for the patient to breathing exercises, and passive and range of motion exercise as advised by the physiotherapist. The benefits of the exercises are prevention of the spasticity of the patient. Main complication of the neuro patients are more spastic. We advised for diclofenac and tolperisol. These medicines are advised for these patients. And prevention of foot drop is also important. If patient have foot drop, we arrange to foot splint to the patients before discharge. It will also, exercise also help to stimulate the blood circulation of patient. Ambulation is also important. Ambulation is
Physiotherapy already spoken a lecture. So can you just ask some questions, because these things are already covered by physiotherapy. Ambulation, quick
Why ambulation is very important for these patients? We try to move out the patient from the bed. It will early ambulation, early recovery of the patients. So we ambulate the patient is important. Prevention of infection is a ventilation. The patient home care settings, well ventilated rooms are arranged for the patients, and the rooms should be the flies are away from the rooms. Flies and dust are away from the rooms, and hand hygiene also maintained for the patients.
Stop it here.
Okay.
Already we are learning late.
Okay. Discharge with a portable ventilator. In our hospital, we discharged 2 patients with a portable ventilator. One in 2016. One patient that last 2
I
years.
arrange money for that. You don't know how difficult to arrange a portable, not only ventilator, how you going to manage at home?
Yes.
It is so difficult to manage a ventilator in ICU. See, the question is
With the
that
trained
sometimes
people.
we do it out of, because there was a patient for 3 years in trauma center. I say enough is enough. He can get a ventilator and go to a district headquarters or a sub-division headquarters, not home. Because if you send home, next day you won't die. You know, that is what happened. Our trauma center had same result as Canada. And as soon as the patient went home, another 26% died. You know that Chirag study?
Yes.
Dr. Deepak and all of you here, we had a Chirag study where we compared 200 trauma patient, head injury patient at Delhi AIMS Trauma Center and 200 in Canada, that is Vancouver. And after our mortality rate in the hospital discharge are same. We had 21%, they had 22%. After 6 months, they had 21% death and we have 46%. 26% people died at home. So what you should highlight, from the hospital you should go to intermediate care. We tried with the Delhi government in 25 years back that we should have from AIMS to home. It's a terrible distance to go cover. It may be Sabdarjung to Gautam Nagar, but it's not half a kilometer. The home care from the ICU care is totally different. So what is necessary when a patient goes from Sabdarjung Hospital AIMS, there should have intermediate care, where there should be less number of caregiver. We told for 10-12 beds there could be 1 nurse, 1 physiotherapist. Here in ICU, we have 1 bed, 1 nurse in our trauma center, right? That type of care we don't want. And that type of patient cannot go home. If you calculate number of bed and number of nurses, it works down to 1 bed and 1 nurse. We have 4,500 nurses in AIMS and 4,500 beds. Is not correct, madam?
Correct.
So we have WHO standard, but we do not have American result. Why? There is a gap.
Yes.
There is a big gap.
So-
Manpower doesn't matter really.
So our home care should be we'll be focusing on empowering the caregivers.
And they should
that
train them.
and that empowerment is possible only if we have a middle level management from the ICU to the home,
Intermediate.
and where the caregivers will be supervised to teach to take care of the patient holistically. And then we also need to focus on organization of care given by the caregivers, and frequent reinforcements is again very, very important as a part of home care. So since we are running short of time,
Anybody want to question? One more question anybody want to ask? They are all in the WhatsApp.
Thank you, sir.
so we
Actually,
invite
they are
the
all from Delhi, they know
third
everything.
speaker, Lieutenant Colonel Yamuna CB, who is going to talk about stress and de-stress techniques for neurotrauma nurses.
May I?
10 minutes.
You have taken half of my time, sir. Okay. A very good afternoon to one and all present here. I bring greetings from all the way from Udhampur, Jammu and Kashmir, Command Hospital. So it's a proud privilege that I am standing in AIMS and talking. So I took an immediate flight and landed here to speak to you all. So, and how's the Josh? How's the Josh? How's the Josh?
Okay, so I think, so that means we are not stressed, right? So let me take you all to a scenario that we have different emotions at different place. So like, you know, some hotel you go, you are very happy, some restaurant, some mall you go, you watch a film, you are very happy. I mean, emotions are like very happy. So, but every day, 8 hours, 10 hours, 12 hours you spent in a hospital, and what is the emotions what people have? Grief, they are in agony, they are thinking what next. So this is the emotions are in the hospitals, right? So here I bring my topic, that stress and de-stress techniques for neurotrauma nurses. So I will be covering my topic under these things, like what is the cause of these stresses among nurses, what are the types of these things, how to identify and manage. If you do not identify, then you will not be able to manage it well. So in a hustle bustle of your trauma room or your intensive care unit, your HDUs, what do we do, a nurse? Sometimes you are just standing thinking confused or means how to manage. So many things, many a times it is seen in the researches that 80% of the nurses are overworked. That's high workload, okay? And sometimes we have uncertainty concerning the treatment or the thing what you are doing. And especially we are talking here about the neurotrauma cases I am saying. It's not like a appendicitis or a cholecystitis patient just getting away out of your ward. It's a neurotrauma, so it takes time, you know. So all these lectures we were going through, it's a long-term care where a lot of people who are involved in that. So these things put us into stress. Witnessing aggression or violence or death in the wards where you are working. Challenging patients and co-workers. This is all the time you see some of the patients are challenging, or the relatives are, or your co-worker is challenging to you. So poor IPR with any of the departments or with your colleagues. Then compassion fatigue. What is compassion fatigue? Because we are dealing with things which people, poor prognosis, sometimes death. So that leads to compassion fatigue for us. And then burnout. Burnout is, I don't need to tell you all what is burnout. Your physical, mental, emotional, spiritual, all sorts of burnout we encounter. So this leads to nothing but stress. Now coming to other, some of the other webs which is related to stress. Role ambiguity and conflict between us. We also sometimes you are in ambiguous situations. What's your role? You are a nurse, you are a multi-talented person who was working and managing all the time. And then understaffing, of course, I said. And then also time pressure. Yesterday's in the neurosurgeons conference, I was seeing race behind time and chase the time. So all the time we are doing that, you are racing behind the time. And today Ma'am Manju was mentioning about the career progress among nurses. Underutilization of these career development options are many a times happens. Like we are working with someone who has not got a chance, or by some chance, I don't blame them for anything. Sometimes, they have not utilized for many reasons. So then, you have a conflict there. But I wish that every one of us uses all these career opportunities to develop every small little course to empower our nursing standards and to reach the nursing excellence as per the NABH accreditation, which is set down all those goals. Now nursing stress points, like in our physical body, there are a lot to say. I'm not going to teach you the theory. I know that all of us are well read about all these things. But the major things are like fear of accidental needle sticks injuries, sore shoulders while pushing the patients, lifting up the patients, then sensory overload. All the time in ICUs and HD you are hearing the alarms. Sometimes you don't even realize that it's a danger alarm, because every time you keep hearing. And I mean, all of you must have even, at home also you keep hearing these, am I right? So this is what the sensory perception, actually speaking, it's all a stress which is happening to our body. Then, like that, many things, which is such a busy slide with, and nurses are the more likely to have musculoskeletal problems than any other professionals in the world, and also leg problems, okay? So what are the stress response of your body? It's your own body which you are carrying all these years. Okay, so your body responds to these stress. That could be behavioral like sleep disturbances, or you may get addicted to alcohol or a drug, or sometimes you become aggressive. Emotional problems like depression, anxiety, irritable. You become irritable to your seniors, your colleagues, your patients itself, Most of the times that's the last thing which you do, to get irritated to a patient or a relative. Okay, so and suicidal thoughts, these things of course it comes with, it's on a higher form of stress leads to. Psychological, physiological, I said about high BP, it can have rapid shallow breathing, many physiological problems can come, biochemical and cognitive issues can come because of this stress. Now, some signs of emotional dysregulations. Why I am saying this? Because you need to identify yourself that you are in stress. Then only you can treat yourself. Okay? So, overly intense emotions that maybe are your matronizing gives you shift your day off to another day. So you get panic. No, ma'am, I can't take this. You have to, like spontaneous response to such situations, impulsive behavior, you become very aggressive to such situations, and lack of emotional awareness, you're not able to understand certain and decide and take a quick decision on something. And like we all are critical care nurses who are working in the situations, and we are the person who have to be open with our senses all the time. Then only you'll be able to, pick up things. Maybe like morning hours, a lot of theory which went on increased ICP. These things, if you are not stabilized with your emotions, you will not be able to pick it up. Okay? And at the end of the day, the patient is going to be the sufferer, which we don't want to happen. Right? And we nurses always we are looking at the benefit of patients. Okay, so in that, what is the most important is the emotional stability. Then trouble making decisions which we make, or inability to manage our own behavior, or we sometimes even avoid the difficult emotions also. So now, so ladies and gentlemen, so that means we have stress among us. So how to wipe that off? Okay, so now we wipe the stress off, and then let's get into stress management. If we are nurses, we have working hours, more working hours and work pressure, so we have stress which is existing. It's our now call to manage the stress. Okay, so how to manage stress? You all know the theory. So it's like, how many of us do regularly exercises? Lift hands. Or you see the so Mahapatra sir, you need to take a real look at the hands raised in aim. So yes, so I will have to take sir response. Your administrator responsible for this. The less of exercise, okay, sir. Okay, so we will ask you all your nurses to take on TD, temporary duties to us, and we'll put them into some physical training on a lighter side, sir.
I think that's true. Some of the nurses should go on rotation to that.
Yes, you can suggest us and take it on a higher this thing. Okay, so we can have, sir, inter-organizational culture mix. That can be done. So, and next is hobby. How many of you really think that years back you had this hobby and you are doing it? How many of you take time out to invest some time in your hobby? How many of you? Okay, it's nice that some of you are really doing your hobby, but I must tell you that we should not forget to make ourselves engaged in our hobby, to make ourselves, that's the one which brings you happiness. Okay, so which reduces your stress. Please invest time in hobby. Okay, it could be anything. It could be just sometimes you making a newer dish, looking at YouTube and making a dish maybe. It need not be a dance or a, something which is structured. It can be anything which gives you pleasure. Okay, and meditations, then yoga, nature loving. How many of us take a cup of, okay, many are there, cup of coffee in the morning and go to a garden and look at those beautiful, small little butterfly sitting in a flower. Do we enjoy such culture in nature? Yes, you must. Yes, so that's very nice. Yes. So these are the things, small little things which gives you more happiness, and that gives your brain neurons are more active. Okay. So suppose these are the measures for us. Music. So I was telling that music should be there even in the wards for the patient. That gives us also happiness. So please listen to music. And suppose all this doesn't work out, then don't hesitate to take therapy, structured therapy. It is not a stigma to go and take counseling. We can say that yes, I have a problem. Please give me counseling. It's okay to say that I have a problem. Okay. Now, there are certain do's and don'ts in the brain. Like for the stress, you say that don't think stress as a threat or a demoralizer or it's a pressure or a disgusting thing. Take it as a challenge. It's a motivator. It's an opportunity for you to perform well. Use stress. It gives you, if you don't have a stress of your matron coming for rounds, then you wouldn't prepare the ward, right? So that's a stress level, you should have it. It's a motivator for you. And, energizing. So let's look at to the stress in that way. Now, we have all keep thinking, and we have thinking errors, which is very inappropriate worries, like discounting the positive. We are more counting on to the negatives than the positive. Don't do that. All or nothing, either everything or else nothing in between we want it. Not right. Jumping into conclusions, all the time jumping into conclusion and making our own assumptions, which is not right. Nothing good ever happens to me. Why me, why me, why me? This is what we think.
Ma'am, just 2 more minutes.
Okay, fine. So I think they're giving me stress to finish. I know, so I take it as you stress. So I have few tips. That's good communications and connectedness with this. These days the term is mindfulness, so please read about mindfulness, how to be in the present situation, how to be aware of your breath, how to be aware of yourself. That's mindfulness. Practice that. Anger management, be assertive, put yourself ahead and please speak for yourself. Okay? Then your humor at work, there are literature says that you should joke around, crack jokes, okay, and laugh it out. Smile, it's a curve which sets everything right, okay, so please keep smiling. Now, this is my workplace. I love CHNC, that is Command Hospital, Northern Command. We all go there. We love that workplace because of certain reason. That this is for the administrators, all your younger crowds. You should see that their mental balance is all the time set up. Give them more of, some comfort things. If they want a day off on a particular day, give them. So these things have to be taken. So then we also will. I love AIMS. I think this thing will come as your hospital also, sir. So always remember, professional, personal balance, career and family, please keep balance. Work-life balance with friends, family, self and work. Have me time, go to beauty parlor, make yourself ready, have good spa and everything. So that's, yes, sir. So that's me time. And mental health check-in, it's okay to get help, seek help. And there are studies which says that nurses are more prone for non-communicable diseases. Let it not happen to us. Hypertension, diabetes away. Okay? So please take enough precautions for that. Identify the problem, take counseling, and then manage your stress. So this is the stress continuum which have peak performance, but let's not break down. And then have a stress-free life and stress-free zone. We will have monitors, wires all around us, but let's be stress-free. And then no point in stressing out something you can't change. Move on and be stronger and stronger, grow stronger. And we, the Command Hospital, are always in the compact nursing care with the soldiers around. We have seen what is life, and a gunshot or anything can take away a person's life and a family. So these are the worries which is all around. But you take, move, grow stronger.
Talk for 10 minutes and they will ask you
Okay. Okay. So here I finish. I wish you all a stress-free life and a stress-free professional days ahead. Thank you.
Excellent presentation, ma'am. Any question?
Anybody can, yes. sir.
Life cannot never be stress-free. There is the positive stress and negative stress.
Yes, sir.
If somebody would not have got electricity addition, and he would not have been. Somebody design aeroplane. So imagine from the stone age today, lot of people have make your life comfortable because taken stress. Stress is positive or negative.
Yes.
It's well described in Gita when Arjuna is stressed. How to take stress? Jindagi is not all ruler like your to the last slide. It is ups and down.
Yes, sir.
And
Yes,
what
sir.
is important? Balance yourself. And for that, what is necessary? Have a timetable. What time you get up? What type of food you eat? When do prayer? Do you have a type? How many of you do prayer every day? How many of you do meditation? How many do pranayam, deep breathing? Deep breathing. When you are stressed, best exercise, sit down
Yes,
quiet,
sir.
do
Yes, sir.
2 minutes deep breathing. If you are upset in the ward, some doctor shouted, go to the duty room, close the door
Deep
and do
breathing.
the deep
Yes.
breathing. Deep breathing, because that is the time you get more oxygen, your brain
Yes,
gets
sir.
nutrition.
Yes, sir. Yes, sir.
Is not
It is
correct?
yes, sir. It is the literature says that you can just open the door, go out.
Ramdev Baba has done all these experiments in Konkhal. Stress induced brain stress and damage
Yes.
to the body, mental damage, cardiothoracic damage, and blood pressure, diabetes, arthritis, all are imbalance between body, mind and soul.
Yes.
You know, Harvard Medical School, every September they have an international conference, Body Mind Medicine. The Brahma Kumari Ashram in Mount Abu, every year August for doctors, there is a Body Mind Medicine. In here, you are in all India, right? Physiology department does every year February Body Mind Medicine. How many have gone? No.
Now it is happening every day. Now Dr. K.K. Deepak has left and Dr. Kochar is running that. Yes. And that is happening between 1 to 2 in the auditorium.
One course, right? They should all attend.
Okay.
So very rightly said that stress is inevitable and we all should be able to identify the stress at
And
a
manage.
early time, and everybody has an individual way of coping with the stress. So we should know our ways and means of coping that stress. All methods don't work on anyone. So we should be like knowing what is my method and that I should be
Why the
Yes.
child cry at birth? If the child doesn't cry, what happened? Is he crying out of pleasure?
No, it's
Why the baby at birth cry? Out of stress for the oxygen. He cries for food. It's the minimum requirement. He cries for distended bladder. Is it not stress?
yes.
There is no mental stress. But
That's
mental
huge
stress
stress.
is autonomic. Even
Yes.
during sleep he get cries because of urine. Wait ho gaya bed. You have not given any mental stress to a baby of 2 months. He is crying. Bladder distended. Wet bed in the winter, nahi?
He is stressed, sir. He is going on ringing the bell now. Okay.
Thank you all the speakers and thank you participants for your active participation.
Thank you. Thank you.
Thank you very much. We have a tea break, na?
We will announce. We will announce.
Tea break, no tea. हम लोग जा रहे हैं। आज केवल ये लोग
Thank you so much.
Attention participants, now because we are having our public lecture at 4 p.m., we are straightly continuing to the session 4, and after session 4 we will be having tea break, and after that everyone is requested to be there in Jawaharlal auditorium downstairs to attend the public lecture, and certificate will be given at 5 p.m. near the registration desk. You have to sign the list. The name, in front of your name you have to sign and you will get the certificate. Thank you so much. You can continue. I know you're all deprived of your tea break now, but I hope you'll all stay for one more hour energetic as you were before. And so, before beginning the fourth session, thank you and a big round of applause to our energetic chairpersons and speakers of the third session. As we are running short of time, as ma'am said, we are moving on to the fourth session. This session will deal with what is otherwise considered as dreaded areas in healthcare services. We know when it comes to saving lives, never giving up is the unwritten mantra that has been instrumental in bringing about such promising advancement to the field of medical science as is evident today. The reason brain death identification and donor optimization is brought under the anvil to blaze the trail forward in saving lives even when all hopes appear to be dashed to all practical purposes. Therefore, it was but imperative that the organizing committee should be so selective in picking out our immense distinguished guests who would be chairing this session. As such, it gives me immense pleasure to invite to the dais Dr. Chavi Sani ma'am, followed by our own dearly beloved Deputy Nursing Superintendents, Ms. Sushila Birla ma'am and Ms. Geeta Bhoria ma'am. Dr. Chavi Sani, Professor, Department of Anesthesia, Pain Medicine and Critical Care, JPM-ATC, AIIMS, New Delhi, whom I personally know to be a very exemplary and committed anesthetist, always available hands-on and indisputably a very diligent mentor and guide to all the residents in her department. All this, no doubt, in addition to her academic excellence, achievements and accolades. Ms. Sushila Birla, Deputy Nursing Superintendent, JPN-ATC, AIIMS, New Delhi. Her awards and honors are Rajiv Gandhi National Excellence Award, Inspiring Leader Award, twice winner of the first prize ARMS for Kayakalp, JPN-ATC. She has attended the training program of the Emergency Medical Human Resources Training Project in Osaka, Delhi at Osaka City University Hospital, Japan. She is a certified expert in national emergency life. She has contributed outstanding service with her problem-solving skills, and her enviable success is chiefly owed to her management competence in the very demanding areas of patient and manpower management and trauma center. Her interests are patient care, disaster management, emergency nursing, and infection control management. Ms. Geeta Bhoria, Deputy Nursing Superintendent, Dr. Rajendra Prasad Center, AIIMS, New Delhi. Her qualifications are General Nursing, Post-BSc Nursing, and MBA in Hospital Administration. She is admired for her amiable nature, proficient management skills, and for creating a stress-free and conducive workplace for all the staff in her center. And for the last time, before our distinguished chairpersons duly announce and introduce the speakers, once again, here's a gentle but no less firm reminder that all speakers are requested to please bear in mind the scheduled public lecture acknowledging the World Head Injury Awareness Day to be held under the auspices of the Director. Also, may I please bring to the attention again to all the delegates that you are requested to attend the said public lecture, whereupon you shall be receiving your certificates at the registration counter at 5 p.m. Thank you all very much in advance for your kind cooperation. Over to you, ma'ams.
have already put up the presentation for it, and I'll conclude that it will waste more time.
आएगा ये नीचे से ही आ जाएगा ना
नीचे नीचे फास्ट है लैपटॉप फास्ट है
Dr. Parul, PGI Chandigarh, challenging of organ donation and way forward.
Good afternoon all. Today we will be discussing about the organ donation challenges and the way forward. Before starting with the challenges, let me give you a brief introduction about the organ donation. Organ donation is of two types. One is live organ donation and the other one is deceased organ donation. A deceased is certified death as brain death and circulatory death if whenever a deceased is there for organ donation. A deceased organ donor can save up to 8 lives through solid organ donation and improve the quality of around 110 patients through tissue organ donation. So we can see the importance, how important an organ donor can be. Starting when the deceased organ donation started in India. In India, the program of deceased organ donation started with the kidney transplantations in 1972. The law for transplantation, that is the Transplantation of Human Organ Act, was passed in 1994 with its amendment in 2011. In India, the mode of consent that we take for any organ donor is an opt-in consent, where the family needs to give the consent, an informed consent, before we go with the retrieval of the organs. Now, why are the challenges why do we need to talk about the challenges in deceased organ donation? As you can see the global scenario where India stands here. Paradoxically, India is the country with the highest population, highest number of road traffic accidents, and highest number of live transplants as well. But when we talk about deceased organ donation, our country stands at one of the lowest numbers in the world. Now, what are the major challenges? There are immense challenges, and in a way you can say there are no challenges, because there is only one main challenge that India is struggling with, and that is the shortage of organs. In fact, not India, but the entire world. And today we will be discussing about 6 major challenges in deceased organ donation. Firstly, the social and the ethical factors. There is a huge lack of awareness and understanding among the masses, the general population, which leads to myths and misconceptions like age, an older donor cannot donate organs, like a cut on the body, and so and so on. And all these are all religious beliefs of the people where they say that their religion does not allow organ donation. All those things are not true. The fear of organ trafficking and illegal transplantation is so much imbibed in our society that it is very challenging for the healthcare workers to even broach the subject of organ donation to the families. And the way forward for all these things is very efficient and effective awareness campaigns. We need very positive media to highlight the benefits of organ donation. We need to address the cultural and the religious beliefs of the people through organizations, through community leaders. And a very challenging, not the challenging, but a debatable topic is the incentivization of deceased organ donation in the country, which many people believe that maybe if we incentivize the deceased organ donation program, it could lead to increase in numbers of the organ donors. Everything has its legal and regulatory issues. Same is the case with organ donation. Talking about the legal framework, there are many gray zones in our act. Even if the next of kin is not available in the hospital, who should be one to give the consent for organ donation, even if the family is willing? Brain death. In the brain death, it will be covered in the next session, in the next topic by Ms. Rachna. And brain death registration in Birth and Death Act. In the registration of Birth and Death Act, only cardiopulmonary arrest is there as death and not brain death, which in itself creates a lot of hurdles in declaring a patient as brain dead. Now strengthening this thing is like bringing all the stakeholders together under one platform to have a stringent protocols, guidelines for the process. As India is a developing country, limited infrastructure, manpower and resources, as we all know, are very limited. And it's not just in the hospital settings in the cities, but especially in the rural areas. Inadequate infrastructure for deceased organ donation, because deceased organ donation requires equipments, they require skilled manpower, trained people who can carry forward the whole process of organ donation. But we have very low number of transplant centers, so people are not actually getting the care that they deserve. Addressing and strengthening the infrastructure could be one of the way forward with excellent critical care facilities, end-of-life care, mandatory retrieval centers in states, training opportunities should be provided to everyone, and knowledge also, not just the training, but the requisite knowledge to take an informed decision is also very important. Now, one of the major things is the communication and consent. Communication, we already had a session where we were talking about emotions just in the previous session. And communication and consent at the point where the family has lost their loved one is very important. It is extremely challenging to talk to such families where they are in grief, in agony. All the family members are in different stages of grief. Some might be in denial, some in bargaining, some even in anger. So we need to very compassionately, sensitively talk to such families about organ donation so that they can give a consent for organ donation after understanding what has happened. Because brain death is such a subject that even the hospital care personnel are not able to understand. And the community at PAR has many misconceptions about all these things. The main challenge that we face is the non-acceptance of brain death, due to which there are loss of missed opportunities of organ donation. Consent is the lack of family consent. Even if a single family member is willing for organ donation, the other family member might not be willing for organ donation. To avoid the conflicts within the family, we always go for organ donation only when all the family members are actually willing for organ donation. Even if a single family member is not willing, we do not proceed. Timely and proper communication, improving collaboration with families, trained people to actually communicate what has happened, and the creation of public trust, that is the need of the hour. Process of organ donation. The process of organ donation is a very time challenging thing. Within 24 hours to 48 hours, there are lot many things that need to be done to save lives. There is lack of coordination among the various teams, the hospitals, the other people involved in the donation process. Identification of potential donors is the major hurdle in India where we actually lose donors. Brain death certification. There are many less number of institutes actually declaring a patient as brain dead. The donor maintenance. Till the time the families are being counseled, the donor actually dies before the decision has come from the family, because it is very challenging to maintain a potential donor in the ICU. To increase all these things, all these challenges to be addressed, we need to address the financial burdens. We need to develop a system for monitoring and evaluation, increasing donor identification and referral, and fostering collaboration among various teams could be the key. After the process of organ donation, when there is no potential recipient in any hospital, the organ need not to be wasted. We need to share those organs, but India being a diverse country has its own challenges with very less connectivity by air and long distances by road. Developing a national organ allocation system and policies for organ wastage. We have actually come a long way. You can see from 800 to 2,765 organ donation. India is actually progressing in the field. At PGI, we have many challenges, but still we keep our to do the deceased organ donation, we try our level best. This is where we counsel the families. This is if the next of kin is not present in the hospital, we actually take the telephonic consents. These are some of the pictures of the green corridors that we create. We have a distance from the airport to our hospital of 45 minutes, but during the green corridor, we cover it in hardly 20 minutes. This is how it works. This is the green corridor that is being created. All the traffic is being halted for the speedy recovery of the organ. And this is how we had 4 donations in a month, and there was a pediatric donation, a young donation, and an old donation. This is a 39 days old neonate who donated the organs, one of the youngest donors in India. And this is how we hand over the body for utmost respect and compassion. And we always do many felicitation programs for awareness of the donor families as well as the community. Thank you. Any questions?
Thank you, Parul. I think you are the right person to speak on this topic.
Yes.
Knowing about PGI and the number of donations that you are doing per year. So, all right, you talked about the challenges. And last year you had 41 donations, you said.
Yes, ma'am.
And for how many patients did you take this video consent?
We
41.
41.
I read 41. I said 41.
Telephonic consent that we took last year was 6, ma'am.
Only 6.
No. We took 41 successful donations. You're talking about the telephonic
consent.
Okay. We took it for 6 patients, ma'am.
6 only?
Yes, ma'am.
And those patients?
If we actually try to get the family to the hospital, the next of kin, we try first with the family to bring the next of kin to the hospital. But if they deny, then we go for this consent.
It's
otherwise,
easy.
yeah.
That's easier in Chandigarh because most of the population is from Punjab and Haryana. No? So in Delhi it is a little difficult.
No, ma'am, it's a big challenge. We have patients from Bihar as well, from
So
Rajasthan.
what do you do for those patients? Because that is the problem that we face here. UP, Bihar,
it's mainly the labor population which we have here, and they have their families back home.
Back home.
So that is one of the main challenges that we face. And
if the family present in the hospital is willing for organ donation, but only the next of kin who has to give the consent is not present, then we go for telephonic consents, and it's taken through the MS in a very stringent protocols are followed for the telephonic consent. So actually we also feel that okay, it's better if the family comes to the hospital itself.
but it's difficult.
Yeah.
Thank you. Any questions?
No, it is like we take a telephonic consent and it is video recorded.
Video.
Yeah.
I just wanted to ask if the person has very kind of reason for all organs donation consent, but then I suppose then also you take from the family member.
Yes. Even if you.
I want to if the person still want to say if my family members don't agree, I still want to donate, then they
You cannot.
like I am.
You cannot.
You cannot ensure that. No, you cannot.
That's.
Why can't you make something like in a not very side, like you can make something like that?
No, actually.
The family members I feel
Are reluctant, yeah. But you know what? When we are alive, it is a big challenge. But believe me, when the near one has gone, the family actually thinks it as their last wish, and they try to fulfill it by hook or by crook. We get calls from across, so many kilometers that okay, our patient is brain dead and we want to donate the organs. But many a times it's not possible. So it's like whenever you talk about organ donation and you want to donate your organs, you pledge your organs, do talk to your families about it. Even if you do not get a positive response at this time, but definitely what you want might be done. Yeah.
Don't worry.
Thank you, sir.
So this is not the next speaker is Rachna Prahan. Last. This is Rachna Prahan. She is the nurse transplant coordinator in Trauma Center AIM. She is awarded by the BSc Nursing from the RAK College, and she have 11-year experience in the Trauma Center emergency. And the topic is the brain death identification and donor optimize, a way to save life after life. Mrs. Prahan, please.
Thank you, ma'am. Okay. So I would like to keep the session a little bit interactive, because the aim of my topic is to basically understand the brain death concept, because while I'm practicing and I'm just working from past 3 years in this field, so many of the healthcare workers are not even aware of this concept, brain death. We might have heard of this word a lot of times, but still there are so many misconceptions among nurses itself. So objective would be just to understand right now, because in 10 minutes this topic is very vast. I won't be able to cover whole details of the brain death concept, but to make us understand that what is the meaning of brain death, as Dr. Parul has already talked about organ donation, and what are the challenges when there is a brain death patient and when he becomes a donor, and for that what are the challenges for optimization. Okay. The type of death, although it is funny to say, because we only are aware of one type of death, that is cardiac death. Okay, that is the irreversible stopping of heart and lung function. Okay, we all are aware of cardiac death. By legal also, when the heart beat stops, so the person dies. Now the second is brain and brainstem death. That is the irreversible stopping of brain functions. As I know, many of the nurses here are working in neuro units. They might have come across this term as this patient is a brain death patient or a potential brain death. So both the terms, whether it is a cardiac death or a brain death, means death only. Okay, we need to understand that both the concepts means death. Finally, the patient is dead. Okay, just keep this thing in mind. But why only consider like brain stem death patient as a donor, and we ask those patients for organ donation? Just to understand that our main vital functions which are maintained in the body are in the brain stem area, that includes midbrain, pons and medulla. And importantly, the control of blood pressure and heart functions and breathing is there. So if we have a brain stem injury or a irreversible loss of function of a brain, we lose our vital signs. Now, the difference between a brain death and a comatose patient. Now, most of the staff will ask me that why not to take the patient who is in coma? What is the criteria? Like, what is the difference between a brain death patient and a comatose patient? So, both the patients are unconscious. Both the patients cannot, even if we give any painful stimuli, they don't give any kind of response. Okay, there is no voluntarily action. But a comatose patient, condition can be reversible or maybe irreversible, or patient stays in a coma situation lifelong. But the brainstem function is intact and that person can maintain his vital functions through that. But a brain death patient or a brainstem death patient cannot maintain his vital functions on their own. Okay, and I would emphasize that it is an irreversible lack of brain function. The term is irreversible loss of brain function, but in comatose patient that can be reversed. Now, causes of brain death can be many. There can be cerebral hypoxia when there is lack of oxygen to the brain, cerebral hemorrhage, head trauma. I am working in a trauma unit. We get a lot of head trauma patients. Okay, the cycle remains the same, that there is some brain injury which will lead to some brain swelling, increased ICP, and ultimately reduced blood flow to the brain. So what happens if any vital organ is not getting enough oxygen? What will happen to that organ? It will die. It will die. Same happens to the brain. It will die. But why to consider a brain death? Because when brain function is lost or a brain stem function is lost, that patient becomes a potential organ donor, because brain is not working, but for certain time heart can still function. Only for certain time heart can still work. Criteria for considering a patient as a brain stem death, that we need to know that patient is having a cause of irreversible structural brain damage, and that patient would be definitely even M1, and he would be needing and ventilator support. Then clinical criteria or clinical prerequisites, what we need to keep in mind, that there should be no hypothermia. We in this system we get on-call shifts also, and we would get a call maybe in the night that we have a potential brain donor, and usually when we go, the patient would be having hypothermia, and when we revert the hypothermia, patient becomes M2 and M3. So there should be no primary hypothermia. When we are checking the reflexes of the patient, there should be no metabolic endocrine disturbances, and most of the time patient would be weaning off from the sedatives in the ICU. So the sedatives are still, they're in the bloodstream, and when their effect goes, sometimes patient's response improves. So we need to make sure that there are no sedatives or muscle relaxants in the bloodstream of the patient. Now, how do we screen a patient? These are the factors that we consider for screening a patient. What is the age, risk factors, about the lifestyle, previous diseases, whether the patient is having any hypertension or diabetes, previous treatment, and a general physical examination, whether the patient is involved in any kind of high risk behavior like tattoos or non-medical injections of drugs. Then what is the hemodynamic status of a patient who is even M1, a potential donor? Current treatment in the ICU, we send blood investigations, and we also check previous investigations for checking whether organs are functioning or not. We do viral markers and blood cultures to rule out any infection, any active viral disease and bacterial infection, and we have faced a pandemic recently, so COVID also has been added, so we need a patient to be COVID negative. Exclusion criteria, all active malignancies are mostly excluded, except any localized carcinoma is there, so we still consider the patient. Any hematological malignancy, we still exclude. Infectious diseases, HIVs, strictly we don't take the patient. And any other active viral disease, if the patient is having, still we are taking, we are doing an expanded donor pool concept. Still we are taking HBS, AG and HCV positive patients to the same, but still we do not consider, we are not keeping that in practice. Any uncontrolled sepsis. So these are the important cranial nerve reflexes, what we keep in mind while checking the patient whether he is a brain death, whether he's having a brain death or not. The GCS have to be even M1, then there should be loss of pupillary reflexes, and it should be, pupils are generally dilated and fixed, they do not respond to any light. Ocular cephalic reflex we also called as a Dolce, so there is absent Dolce sign. Corneal reflex, there is no response when we touch a cotton swab to cornea. Then we also do a cold saline test, we put it in one of the ear and we see that there is any eye movement or not. But in a brain death patient, none of the reflexes will be present. Then we check gag and cough reflex, and most importantly absence of spontaneous respiration, because those vital functions are needed to support other vital organs. Now how do we establish? We do a apnea test. I think most of the people have heard of the apnea test. These are the simple steps. Measuring we take a ABG before that, doing an apnea test. We hypersaturate the patient with oxygen, then we disconnect the patient from the ventilator and we insert a oxygen cannula to the endotracheal tube. Then we watch the patient for any hemodynamic instability. If there is any, then we will stop the test at that time. And after 10 minutes, we repeat an ABG. So during those 10 minutes, there shouldn't be any respiratory effort seen in the patient, and there should be a rise of minimum 20 mm of HG would be considered as a positive apnea test. Like this is an example, and this is a live example of a patient which we did. Here PCO2 is 45 and after apnea test it was 74. But it's not a challenge to conduct an apnea test. It hardly take 10 minutes. But to make the patient reach to up to that point where we can do an apnea test, it's really challenging. Now some conditions which are compatible with brain death, I would just play the video. Because this is a corner where we really suffer. Now this patient, when we give any painful stimuli, will not give any response. But when we give a spinal stimulus, this patient will give this kind of response. There is no response, but when we give a spinal stimulus, patient will flexes. Now at this point we would, even neurosurgery residents will come and fight, this patient is M5, why are you thinking this patient is brain dead? So this is a classic sign of Lazarus reflex, and sometimes we do have such kind of reflexes in a brain death patient, okay, but this is compatible with brain death. Patient can have a loss of brain function, but spinal reflexes, they still remain intact for a while. Okay, so this is the, okay, all right. Brain death certification is done by the team of 4 doctors. According to the TOA Act, there is a Form 10, which has to be done by 4 doctors, that is the hospital in charge, 1 person nominated from the brain death committee, neurologist, and a RMP of who is treating the patient.
Rachnath Rangam, please go fast.
Okay. So I'll just skip to my last slide. That is the role of nurse in donor management. First is, as Dr. Parul said, identification of the potential donor is very important. We have to increase our donor pool because half of the patients goes missing when we are not able to identify who is a potential donor. Then maintenance of the hemodynamic stability takes lot of ICU resources, patient especially who is a brain dead. Ensure complete gathering of the information, that who is the next kin of the patient and how will we get the consent and what is the right history of the patient. Ensuring all the samplings and microbiological screenings that is very much required for a potential donor and even for an eligible donor. Communication and family approach, and obviously follow up of the recipients who have received the organs. Okay, thank you.
Thank you, Ms. Rachnath Rangam. Very well explained. Thank you. Any questions?
Any questions, no? So Rachna is actually the backbone of our program at AIMS Trauma Center. And yesterday only we had a donation. So these people are really working hard. They keep a record of all the potential donors that we have in the trauma center and management till the time the organs are retrieved. So thank you so much, Rachna. Thank you. Next we have Major Gayatri. Major Gayatri B, who will be talking about the bad news. It's bad news, but we have to get on and deal with it.
Respected dignitaries on the dais, ladies and gentlemen, I would like to thank our organization as well as AIMS organization who has given this opportunity to speak in front of you all today. It gives immense pleasure to stand here and talk in front of you all regarding bad news. My topic of presentation today is, it's bad news, we have to go and deal with it. So I'll be covering my topic under the following headings. What is definition of the bad news? Bad news, Dr. Robert Buckman defined in 1992 defined bad news as any information that adversely and seriously affects an individual view of his or her future. Here we have some examples of bad news in medicine, that is traumatic death, death after chronic illness, death after diagnosis of a cancer, diagnosis of chronic illness, diagnosis of permanent disability or a birth defect. Why we need to break the bad news? Because it forms a part of clinical practice and it's a skill that can be taught and improved. If we do it well, patient and relatives will appreciate it, and also it will empower them. It will facilitate the open discussion, thereby it reduces the stress among the family members as well as the health team members. It will also help in the better psychological adjustment of the family. Non-disclosure of bad news is no longer considered as an ethical practice. Here there is some study which states what is our nurse's perspective on breaking bad news to the patient and the family by Abbas in 2014. So they have conducted a depth and semi-structure interview among 90 nurses who had working in one of the hospital in Iran. They have found that even though it's a physician job, the nurses plays a very important role in delivering the bad news to the patient and the family. So therefore, nurses has to be trained well to give a bad news in an effective manner. To whom we give the bad news? Obviously it is for a bereaved family. So in case both the parents are injured, children are minor, we have to give the bad news to the next of the kin of the family. At the same time, hospital superintendent of the hospital, medical superintendent of the hospital has to be informed at the same time. Here, when we deliver the bad news, we have to follow some principles that when to give the information. We have to give the information when we know complete about the information. And where to give the information, we have to give in privacy, and it should be given in the phone, and it should be given by person. And so always when we give the bad news to the patient and patient family, supportive person always should be present. Here we have around the world there are several protocols which are followed based on the scenario to break the bad news. Some of them are Rabo and Neckpiece ABCD approach, Dale and Buck Spikes approach. We have a break approach, patient approach, psyche emergency approach, Sunburn protocol and grieving protocol. We'll see one by one. Rabo and Neckpiece has developed the ABCD approach in the year 1999. Here, A stands for advanced preparation. In the advanced preparation, we have to review the history, see the patient diagnosis, what are the possible treatment options which are available, what is the prognosis of the patient, what is the treatment option available. We have to do the mental rehearsal of what we are going to talk to the patient and do the list down the whatever word should be used to the patient when we are delivering the bad news to the patient and what should not be used. And next we have a build therapeutic relationship and environment. Here we have to make a seating arrangement in this private room in such a way that we will be able to maintain eye contact with everyone. So C stands for communicate well in the patient understandable language. whichever language the patient may be, and deal with the patients and once we tell the bad news, they start addressing their emotions. Some of them will be in the denial, some of them will be in the bargaining stage, some of them will be in acceptance stage. So we have to address their the emotions as it arises, and we have to actively listen to them, encourage them to show their feeling, express their feeling, and we have to deal with them empathetically. Finally, we have to encourage and validate the emotions. So it's breaking bad news. It's emotionally challenging for the healthcare professional also. Before attending the patients, we also have to look into our emotions when we are going to the next patients. So, next we have a Bail Bugs spike protocol. Here, S stands for SETI. It should be separate room, distraction should be free, phones should be switched off. We have to involve only relevant health team member as well as the family members. We should know what patient knows about the bad news. So that is a perception. In invitation, whether patient wants to know how much they want to know, whether they are ready to listen to your bad news, that we have to check before delivering the bad news. So once we can involve the family members and we can introduce our health team members to the family members as well as to family members to the healthcare team, and once we can ask whichever the family member who was in a contact with the treating physician, and once they say what do you know about the patient current condition, once they know that their present condition is this, so we can start telling the information in a piece of information at one time in their understandable language. Once we tell them information to them, obviously they will be having bargaining, acceptance, and some of them will be so aggressive. So we should have a safety exit also in the room where we are conducting the bad news to the patient. And finally we should have finally do the summary of the session, whatever we have told them, and same way we should have a strategy. We have to look into our emotions before going to the next patients. Next we have a breaks protocol which was developed by Dr. Narayana Mittal in the year 2010. Here D stands for background, R for rapport, E for explore, A for announce, and K for kindle, and S for summarize. So before knowing the delivering the bad news to the patient, we should know complete educational, financial, social, cultural background of the patient and develop a good rapport, explore what they know and start from there about the bad news. Announce that you have a bad news by giving warning shoot. For example, your CT report seems to be abnormal, it's not normal. So then after that we have to handle your emotions with empathy and quickly do the summary of the session. Next we have a presenting protocol which was developed by Dr. Carolina Rebelo Pereira in the year 2016 in Brazil. Here P stands for prepare, S for assess how much patient want to know and how much they wanted to how much they know and how much they want to know. C means convey to validate in Portuguese, means invite the patient for the truth. I for inform, E for emotions. N for nano abandon the patient, don't abandon the patient. T trace a strategy, outline a strategy. Next we have a Psyche protocol which was developed by Dr. Mohammed Psyche in the in the Pakistan Institute of Medical Science in Islamabad in the year 2004. Here, S stands for set the scene as soon as possible. A means assess the understanding of the patient attended, alert them that you have a bad news for them, inform them in their own clear, understandable language, quickly do the summary of the session. Next, we have a Burns protocol. Burns protocol, till now whatever protocols I have told, it's mainly meant for primary and palliative care of the patients with a different disease condition. But some protocol specially meant for a trauma and acute care setting, which was developed by Dr. David and team in the University of North Dakota, USA in February 2022. Here S stands for setup, E for understand the emotions, N for notify, B for brief, narrative and break the bad news, understand their emotions, respond well, and next steps. In case if patient had trauma and the patient has died, so family members has to be given a chance to see the patient, and before seeing the patient we should make sure patient body should be presentable to their loved one. All the tubings has to be removed, and the ECG gel, if it is there, has to be removed. Even if all dress is soiled with the blood, it has to be removed. And we have to change the dress, and we have to go and tell the bad news to the patient relatives. Next, we have a grieving protocol, which was developed by Dr. Cherry Hubden in the year 2005. It is mainly used for death notification in the emergency department. Here, G stands for gather the family, R for resources, call for support to assist the family, I for identify yourself, the deceased person family as well as knowledge which should be disclosed to them, educate them that event has occurred to their loved one in the emergency, verify that their family member has been died, give them some space and time for the emotional moment and to absorb the information. Next we have, in inquiry we have asked if they have any questions, answer them all, and inquire if they are willing for organ donation. You can proceed for with the help of transplant coordinator, and we can, the last step is give them your card or contact information, offer them answer if they have any questions which may arise later. Next, what is our role as a nurse in breaking bad news? As I told, in all the protocols, preparation is must. So self-preparation is must for breaking bad news. So we have to self-preparation, we have to arrange, prepare ourselves before delivering the patient, bad news to the patient, and arrange a quiet private room, schedule adequate time, involve only relevant family member as well as healthcare team, ask open-ended questions, use clear language in case if doctor doesn't know the patient's language, if we know, we can translate the patient language in their own language, and control the noise once they start announce the news, so they start quarreling each other family. So in that time we have to control the noise and don't avoid them, when they start crying, don't allow them not to cry. So please allow them to cry. So we have to deal their emotions empathetically, be calm and sensitive, be empathetic, tactful, and in case if death has already happened, to explain the motor resuscitation protocols which we have followed, allow some space and time for the family, and help them to go through the grief process. Also appreciate their effort to save the patient, allow them to express their feeling and see the deceased patient. So as I already mentioned, we have to make the patient body or deceased person which is presentable to their loved one. Provide support to them as well as in case of emergency we have to take a consent for autopsy. Here we have some of the do of and don'ts of breaking bad news. Be calm and prepare yourself, be honest, look up to your body language as well as tone of your voice, actively listen to them, give a chance to talk, and give only relevant information at a piece of information at a time, repeat the information if required, be empathetic. Here we have some don'ts. Don't be rude and judgmental, don't give the bad news over the phone, don't interrupt and don't smile when you give the bad news to the patient, don't keep the patient in suspense, don't use any medical terms when the patient don't understand, and don't give them any advice unless they are asked. So here there are some literature reviews based on the breaking bad news protocol. Placenta protocol, which was the proposed protocol which was used for Brazilian contest. Another was protocol on Aisha Anwar, which was conducted in the year 2020, a qualitative approach to explore the doctor's perspective and experience in tertiary care hospital. Here participants have described that breaking bad news is a difficult task. Their experience may vary from very bad to not bad to very bad. And they said also it is difficult to break the bad news in case of children, young adults, as well as in acute conditions. So they have said even breaking bad news it will affect them emotionally, physically, as well as mentally. And here's another study by Osmosis team which was published in 2021. Same has been updated in the year 2022. So they have told which are breaking bad news by using either SPICE protocol or BREAKS protocol. They have recommended that SPICE protocol has been used from the longer time, but BREAKS protocol also is work for some of them. So they have told whichever is you feel it's right for you, that can be practiced, and each meeting won't go smoothly, some will go smoothly, some will go very hard. So sit back and do work where you went wrong and be ready for the next time. Here another study which shows breaking bad news protocols, reviews and recommendations. Here among 14 studies, these are 6 protocols which are more frequently used. Common pitfalls of breaking bad news are inadequate information, giving news in speed, false assurance, not giving time to response, removing all hopes, allowing denial to remain, failure to understand the patient feeling. Take home message. So breaking bad news, it's not a simple task. It's a very challenging, difficult task, so which all we encounter. Most of the time we all want all the nurses won't be, I don't think so, all of us will be involved in the breaking bad news. Only few of them are involved, but still, these protocols and good communications will help to deliver this bad news to the patient in a good manner, as well as if we break the bad news in an effective manner, it will always have a positive impact on the hospital as well as the healthcare team. So, these are the few references. Breaking bad news is an art. So I end my presentation with the Buckman quote: if we do it badly, the patients and family members will never forgive us. If we do it well, they never forget us. Thank you.
Thank you, Major Gayatri. First, for sticking to time limit. Second, for such an elaborate talk. And yes, it is one of the most difficult part, breaking bad news. And in fact, not only for the nurses, even for the doctors. I mean,
since they have told me nursing symposium, I have conducted neuro party only, ma'am.
Yeah. In fact, when I am there, I used to be there for this organ donation. It is so difficult that you also get emotionally involved. I used to start crying. So it is really difficult, and it's an art, which we all have to learn. You cannot go without preparation for breaking bad news. Thank you so much for such informative and elaborate talk, Major Gayatri.
Thank you, ma'am.
Now we have to wait.
Thank you. Thank you. Without any further ado, but with all due respect to our distinguished chief guests, esteemed chairpersons, and the very receptive delegates, I would like to extend our sincere gratitude on behalf of the Department of Neurosurgery, Neurosciences, and Jayaprakash Narayan Apex Trauma Center, AIIMS, New Delhi, for making this symposium possible and rendering it a grand success. Thank you for your esteemed presence.
A bouquet of heartfelt thanks is also owed to the organizing committee, particularly for arranging the venue, food, sound system, including audiovisual support, not to forget the necessary technical support facilitated by the computer facility team, and last but not the least, to all the various medical professionals who worked on and behind the scenes. It is indeed a joy to savor the fruits of such an effective teamwork. So once again, thank you to each one of you.
I would like to thank both of the anchors. They have really done very good troubleshooting today for all the issues we were having here, and they have really controlled all the events which were happening here. Thank you to Nicole and Rachel. Your efforts are really, I don't have.
And thank you whole team. So please be there in the Jawaharlal Nehru Auditorium. Public lecture is going on. So please assemble there as soon as possible, and you can collect your certificates at 5 p.m.
As we are signing out, I would like to thank my co-anchor, Ms. Nicole Johnson. Her desire and willingness fueled our mutual efforts. She put in her best endeavors to navigate the flow of events. Thank you so much, Nicole. So signing out, your hosts, myself, Rachel,
Nicole, Trauma OT.
We wish you a great evening. Thank you so much for being here.
Thank you.
Thank you. And please assemble down at the auditorium.
It's in my bag. It's with me.